So now quickly we're going to see the seronegative spondiloarthropaties. We have spondylitis, ankylosing spondylitis, reactive arthritis, enteropathy, and psoriatic arthritis. In psoriatic arthritis, the patient has sausage shape, that is dactylitis, plus the rash syndrome psoriasis. In the X-ray, we will see the pencil in cup deformity. In the enteropathy, is just the patient has usually inflammatory bowel disease plus involvement of enthesitis, ankylosis of the sacroiliac joints or around there. And then the reactive arthritis is divided into Reiter syndrome and the other. Reactive arthritis is the triad of conjunctivitis, arthritis, and urethritis in the case of Reiter. This is the triad, and in Reiter we have a non-gonococcal urethritis, that is, we're talking about chlamydia or uroplasma. If we have the other one, it's because it is not associated with a urethritis, it's associated with a diarrhea from Salmonella, Shigella, Yersinia, or Campylobacter jejuni. Patients with reactive arthritis will also have keratoderma blemorrhagicum, that is lesions around or in the palms and soles, and patients has circinata balanitis, that are lesions around the head penis, urethritis, ulcers, cervicitis. And in patients with HIV, they can have a very severe or aggressive skin lesion. That will be resolved if the patient is consistent with the antiretroviral therapy. And there are some studies that suggest that tetracycline can decrease the period of the symptoms. And lastly, we have ankylosing spondylitis. Here, the patient has enthesitis of the sacroiliac joint and ankylosis. Ankylosis is diffusion of the joint. Later on in the disease, they will have ankylosis of the costosternal and costovertebral joint. These patients would have uveitis and aortitis that would lead to aortic regurgitation or aortic insufficiency. We believe that is because of increased interleukin 17 that in some way activates osteoclast, and so we have osteophyte formation. The treatment for these conditions are NSAIDs. For refractive treatment, we will give anti-tumor necrosis factor antibodies that are adalimumab, infliximab, etc. And for more severe cases, antibodies against interleukin 17, like secukinumab. Or for psoriatic arthritis, we could also give monoclonal antibodies against interleukin 12 and 23. That could be ustekinumab. So these seronegative spondyloarthropathies have in common that they have uveitis, they have enthesitis, ankylosis. The patient gets better during physical activity, gets worse in the morning, early in the morning. Is associated with a HLA-B27 that will aid in the probability that the patient has it. The X-ray, the MRI can show early signs like embolication before the X-ray, so the gold standard will be the MRI.